Welcome to the Functional Code, your go-to source for decoding optimal health. Join Dr. Addy and Dr. Jace as they break down the science behind pain, performance, longevity, and more, making complex concepts easy for you to understand and apply in your life. Your journey to a healthier you begins with understanding the Functional Code.
Disclaimer: the content provided in this health podcast is for informational purposes only and is not intended as a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you have heard on this podcast. If you think you may have a medical emergency, call your doctor or 911 immediately. Reliance on any information provided in this podcast is solely at your own risk. The creators and hosts of this podcast are not responsible for any actions or decisions you may take based on the information presented.
Welcome back, everyone, to the Functional Code. Today we're on episode 7, the body series, going over the thoracic spine, rib cage, and everything else torso. I'm Dr. Jace.
Hello, I'm Dr. Addy. So today we're going to hit on the facts and evolution of how we adapted to get our torso, and it's a very unique part of our body. We're going to hit on that. We're going to talk anatomy, physiology of the thoracic spine, rib cage, other parts of the torso, and we're going to talk about how rib cage pain, thoracic pain has been treated, and what are the kinds of conditions that we commonly see in the thoracic spine. We're going to talk surgery versus non-surgical, what are the best ways to manage these conditions, and then finally we're going to talk about breath work and how that can contribute to your rib cage movement, your thoracic spine pain, just overall improvement of lung function, since that's just a huge part to the rib cage and thoracic spine area. And then lastly, tools that you can use to continue to put good health into the thoracic spine, rib cage, and other ways to prevent injury. So first and foremost, Doc, we were talking before the podcast just how crazy the unique structure of our torso is, and not many people really understand, as we've evolved as humans, just how interesting the thoracic spine and our elongated, narrow, but very strong torso is. And so if you just wanted to first start off with this incredible structure, and why is it so unique and different?
Yeah, no, that's a good point. And yeah, when you look back on the evolution of hundreds of thousands of years ago, when we were scavenging the earth, oftentimes we found ourselves on all fours or quadrupeds. We were also in trees, hanging, wherever we could do to adapt to the environment around us. Now, as we went to twos in terms of bipedalism, we noticed a couple different things going back and looking at bones and looking at some of the people that study individuals and humans from hundreds of thousands of years ago. And there's a few differences that they noticed. So, first off, the rib cage changed from more of a structure going more like top down, not as barrel shaped. The ribs didn't have as much roundness to them, and as we opened up, standing up against gravity, it allowed us to adapt, expand the ribs and diaphragm, which then allows us to take a breath. There's a few things that I have to theorize on that I don't think we'll ever know. I think this is also where the adaptation of the vagus nerve came into play to calm the system down. As we're moving on all fours or hanging in the trees, as we stop to take a break, they allowed themselves to sit up, which then allows the chest to open and contract a little bit more fluently. It also allowed them to calm the system down, thus the vagus nerve connection, and also where the fastest way we physically know how to de-stress or calm the body down is via the double inhale exhale. And just by doing that, sitting upright, that connection via the vagus nerve to calm down more, so a little bit easier. Now, just even on that topic, when they were eating, and this is where people that go out and explore the Amazon, they look at indigenous tribes. Every time they eat or gather in a group setting, they are seated not in a chair, sometimes on the ground, but more times than not squatting. And when they squat, What is that doing? Well, it doesn't allow the shoulder blades and the rib cage to take the breath. It forces more movement on the belly. And when it does that, there's pretty much 3 organs that have muscles. First off, heart, second, stomach, and third, bladder. Every other organ needs movement in order for the repair process, the digestion and excretion of waste products. So when you're seated and you eat, it forces each breath to go through the stomach, thus allows for more movement and better proper function of the whole chest cavity, torso region. Ideally go into the edge of the chair, bring your heels back with the feet on the ground, sit upright, and then try eating from there. I know I've tried eating when squatting, sometimes camping, but it doesn't happen too often, so I'd definitely advise you to try it out, see how well it works for you. But I guess, Doc, have you ever done any squatting when eating before for periods of time?
No, that's really interesting, actually. I didn't even think about that. But what I do know is, I bet you there are a lot of patients who haven't squatted in many years, and they have yet to try. And I bet you if you're one of those who are listening to the podcast and you're like, when's the last time have I actually like sat down on my calves to just sit there for a while? I bet you a lot of you feel like you haven't done that in a while. And that's actually something I do daily. I mean, I'll be in between patients and I will squat down on my calves and I'll stretch and I'll move, and I'm just always continually trying to put myself in those types of motions.
I love it.
But what I think is interesting is when you talked about how it almost forces you to diaphragmatic breathe when you're in that position, and that's what I want to hit on. It's as we've evolved, we've become very poor breathers, and I shouldn't even say evolved, because we're kind of, this is just kind of recent how we've come out within let's say the last 50 years of just worsening health and overeating, obesity. That is what's leading to poor breathing. It's excessive weight, excessive strain on this body of ours, and especially around the torso, because most of that is abdominal weight. And so with that increased weight and with those increased health conditions, we have just become poor breathers. And when we don't have the ability to diaphragmatic breathe, it can really, really cause a lot of other things. We even know that as just differences in tension and pain around the neck and the back. So I don't know how many times where we'll have patients that will continually not improve, and we get to the point where it's like, okay, now, well, what else can we help you with? Because for some reason you're not improving, and we take a look at their breath, and they are still just adding such big breaths. Their shoulders are moving and they're not diaphragmatic breathing, and that's causing so much tension up into the neck and around those muscles that should just be accessory. They shouldn't be doing the bulk of the breathing. So we're going to get into the breath later on in the podcast, but I definitely think that's a great way for those to practice, is try to shut off anything that is going to cause you to do big chest breathing and shoulder breathing, is getting down, squatting, and trying to diaphragmatic breathe. So that's really beautiful that you had brought that up.
Cool.
With the way that the torso is created, Doctor, you just want to break down anatomy, physiology-wise, of the thoracic spine and the ribs, and just how they connect, obviously, to our shoulders, our pelvis, and pretty much everywhere above and below this area.
Yeah, when we look at this structure, especially the thoracic spine, the mid-back, torso, every movement is core to extremity movement. Every step, every throw, every reach, pull, it all goes through the rib cage, mid-back, spine, and how it connects to the neck and lower back. Now, with the thoracic spine, there's 12 segments separated by discs. There's also ribs that attach on the back side and wrap around to connect to the front. Between the thoracic spine and the cervical spine, there's a difference in how the joints or facets are laid down. So the neck, they are laid down more of a 45-degree angle off to the side. And then as we go more to the transition from the neck to the mid-back, that then curves to where most of the joints are facing almost like side to side. And that allows us to allow rotation and twisting movements mainly in the mid-back, but also in the thoracolumbar junction, or the TL junction, when it goes from the joints off to the side to almost straight face forward and backwards. So, and how we look at the differences and categorize the spine, a lot of it is the shape of the bone or the vertebral body, and also the joints. And we look at that, and not only of how we have adapted, but also how we can improve the function and the capabilities of what the human body can perform. Now with the rib cage, there's a couple interesting factors. The ribs between ribs 1 through 7, known as true ribs, they go from the spine and connect to the sternum. There's also what's known as false ribs, which is from the 8th to the 10th ribs, and they go from the back to connect to cartilage, and the cartilage then connects to the sternum. And then the 11th and 12th ribs on the bottom, those are known as floating ribs. Those go off to the side, and oftentimes, and this is where people are theorizing why those are adapted there, to protect blows from the side and also to protect internal organs, especially our kidneys. So when we look at all this together, the huge main factor, and we're going to get into breathing here in a little bit, that how you can open up, expand, and relax the ribs. And if you're not able to do that, or if you have this weird pain when breathing, oftentimes that can be contracture or limitations between the intercostal space and how the ribs connect or collapse on one another, and it doesn't allow breathing, and or it forces compensation above or below the area, or in front of or behind the area. So looking at the whole rib cage as a whole is incredibly important to go into the assessment of this structure. So the last thing I want to go into is the muscle structure, and this is not meant to be an anatomy or physiology session, but I think it's very important for everyone to understand their whole system on what's going on. So to connect the lower back, the pelvis, to the lumbar and thoracic region, there's muscles on the front of the spine known as the psoas muscle, and that goes and attaches to the legs. But more for the thoracic spine, there's the transverse abdominal muscles, internal external oblique, which connects the rib cage to the pelvis. There's also tissues on the back which go from the spine out to the shoulder blades, the shoulder blades up to the neck. There's also tissues of like the levator, which go from the neck to the shoulder blade. There's also tissues that go from the rib cage to the shoulder blade. So everything is connected, a lot of which via muscle structure, but how our arms are even hanging on our body, all is through the sternocleidomastoid joint, which connects on the front of our body, on the bottom portion of our neck. And that has a huge connection, not only between the muscles of the attached from the neck, they also go to the ribs, known as the scalenes. So as we're leaning forward for periods of time at the desk, if we're not working on these tissues, it's going to force more strain on the muscles on the front side, the structures on the front side, and it's going to lead to other conditions, problems from there. So when you look at the rib cage, everything's connected, especially through the torso, and how we go about assessing this, and where practitioners need to look at this more in depth, is how not only is the area of discomfort, dysfunction affected, how are the other areas compensating above and below and from on the front side and back side. So,
absolutely. And I don't think a lot of people know, Doc, just how high the rib cage starts. Especially even, I don't know if you've obviously noticed when we start assessing the patients and we say, oh, you know, your ribs feel very either out of place or tense up into obviously rib 1 or 2 area. And they're like, wow, really? I have ribs up there. And yeah, it's incredible that you have that much protection up there. But when you think about it, that's what is going to, like Doc said, connect part of the rib cage to the next parts of the body, which is either above, to the side, or below it. But I always find that fascinating when I have that question from patients who just didn't realize that, like, your torso, your rib cage is almost pretty much the entire size of your entire body and torso. But I also wanted to point out this one thing you said, when the facet joints, or the joints that allow movement in the spine, start to round out, that's just another way of us saying it's imperative that you keep rotation as a keystone to the thoracic spine. So when you're thinking about just how important the thoracic spine is, one of the main ways that you can assess that is going to be with rotation. Doc, is that correct?
Absolutely.
Yep.
Yeah.
So with rotation, we're going to show you some ways, obviously, to assess that and to improve rotation, because so much of the torso's rotation comes from the thoracic spine. And it's obviously, like we had talked about, how the shoulder was connected to rotation. How much shoulder limitation can prevent you from good rotation as well.
Good point.
And so these are just some things that I want you guys to take note when Doc was talking about this, just how much this is connected to each other part of the body. Like, this is the core of you. And when we say core, we actually mean it. Like, your core muscle, this is your core. This is the structure that is going to be the middle of you and connected to every single part of you, up, down, left, and right. But yeah, I just wanted to touch on that, Doc.
And then just even to go on what Dr. Addy was saying, when we go over some of the conditions, you're going to start noticing some common tendencies, almost exactly what he said with the shoulder problems on the front side and how that can round the whole rib cage, torso rounded forward, and then what conditions can come up from there. So we want to start at the basics and the understanding, and then from there, if anything deviates for periods of time, the body has no other way other than to either compensate or break down, thus conditions come from there. But yeah,
right.
That's a really good point.
Right. And I think one of the first conditions we can bring up, which I think is going to make you understand what we're talking about the clearest, and maybe the most exaggerated part of a condition that is effective to this part of the body, is going to be scoliosis.
Yes.
And Doc, do you just want to hit first on what scoliosis is and how it changes the thoracic spine so drastically, and then maybe we'll jump into just how it's managed and how we manage it, and then the differences between the two.
Yeah, good point. So when you look at scoliosis, that is curvature of the spine, whether it's just the lower back, whether it's the whole spine itself. When we look at this, oftentimes we see this as a practitioner standpoint on a weekly basis, for sure, almost every single day, to a certain extent, depending where we're at in our practice, if we will. But when we look at scoliosis, there is not only tilting from side to side, but there's rotation and tilting for most people. And that throws the structure off quite a bit, and it forces different mechanical issues on how you function, whether it's reaching, pulling, walking, running. Like, yes, you can perform athletic movements, you can play sports if you have scoliosis. However, it can limit your potential significantly. So when we look at not only the spine and how it twists and rotates, also looking at the connection of the rib cage. So for example, if the spine is twisted off to the side, whatever way it twists to, the rib cage has to compensate to move in almost the opposite direction. So like, for example, if we're twisting our body to the right, it forces the rib cage to come back, to almost compress those two areas together, but it forces the body to not only be able to breathe properly, but the muscle structure connecting between the rib cage, the spine, the shoulder blade, that all plays a part. So the body is going to adapt over time. Now, when we look at this, ideally, if you know that you have scoliosis earlier in life, you're way more malleable and you're able to adapt much easier. So ideally, you want to get this under control sooner than later. Oftentimes in schools, they do what's known as the Adams test, where they look at your spine, they put their hands on the back, you lean down, and they notice, is there a curvature one? Or if it goes down, does the curve come back to center? Does it not, in terms of functional or structural scoliosis, or curvature, if we will. But I think we need to do a step further. If you start noticing problems with breathing, other vascular issues, noticing that a shoulder at a young age is higher or lower than one another, or the pelvis is wonky or twisted, I think it's very important to go get a screening from a practitioner, professional that deals not only with the spine, but scoliosis as well. And I know there's other things that can come up with this, but as Doc, let's dive into some of the, like, either the research and what's your take on patients that you've seen with scoliosis?
You'd be surprised that one of the most common symptoms that is reported in adolescents with scoliosis is actually fatigue.
Good point.
And you'd be surprised to note that it's not the first thing, obviously, that parents would think about when their kid says that they're tired. Maybe they're thinking that they aren't sleeping very well, they're eating too much junk food, or that's just obviously creating a fatigue or tiredness to them. But when you think about the structure of the spine and its correlating musculature, and you have such a drastic curvature change, those tissues are actually fighting to create any more balance possible that it already knows. So it's that increased muscle fighting in a way that is causing expenditure of energy, which again also can wear down someone if they're trying to grow as adolescents. So fatigue is going to be something that comes up a lot with those who have scoliosis. Another thing too is you may actually have no idea that they have scoliosis.
Yes.
And I know it's already difficult enough to be a parent and to keep and trying to figure out, what else do I got to worry about with my kid? But if the kids by all means do not have a, and I don't know about schools nowadays, whether they even do these screenings or not anymore. I know I did when I was a kid, but
Same.
I'm not sure if they even do this anymore. But just making sure they see a chiropractor or a body specialist earlier on in life is a great way, because we will preventatively screen them, usually with an x-ray, which is a very, very safe, quick way to assess that. If not, obviously a medical provider to at least do a physical earlier on in life. They might catch it too if they're doing a thorough exam. But
Yes.
Like Doc said, earlier on in life is better, because what we're about to jump into regarding the surgical versus non-surgical outcomes of treating scoliosis, especially in adolescents, this matters. Catching this earlier matters, like Doc said. So
Significantly.
that's kind of how I want to segue into these studies that we have for you today. And we're going to start first with scoliosis, surgical versus non-surgical for adolescents. And again, this is a systematic review, meta-analysis, so it's a very, very, what we would call a higher quality study. And what they found was surgical interventions such as fusion with instrumentation resulted in better correction of spinal deformity and improvement of quality of life compared to non-surgical approaches such as bracing or observation. Authors concluded that surgery may be more effective in preventing curve progression and improving long-term outcomes in adolescents. Now, this was in 2016, so this was, almost 10 years ago. And it's not to say that surgery, in our opinions, isn't effective, but what we want you to know is there have been better studies that have come out every year, and we're going to talk later on, obviously, about what we feel the parents should think about first before doing surgery. So again, another study was 2017, just showing long-term outcomes of surgical treatment for scoliosis, and just concluded that surgery can be effective for treating or reducing pain and disability associated with adult scoliosis. So these are obviously patients probably past the age of 21. So both adolescent and adult scoliosis, there is good research to show surgical intervention is appropriate. But what does appropriate mean, and where should intervention take place in our opinions? Now again, we're not surgeons by any means, but you'd be surprised at how many patients we've helped to avoid surgery with non-surgical operative treatment. So,
Yes.
Doc, I know before we jump into non-surgical, is there anything that you want to talk about when it comes to surgery for scoliosis?
No, I like what you said there. The conservative route is way more important to understand if you have scoliosis or if you have curvature or adaptations of the spine. It's just more beneficial to get it looked at earlier on in life, and then do periodic checkups on your body as you progress in the stages of life. But yeah, no, we can dive into some of the other topics.
Yeah, I just wanted to also add, there will come a time where surgery is needed for some of these scoliosis patients. We were talking before the podcast, Doc had asked me, he's like, to what degree of scoliosis? And as providers, when we talk degrees of scoliosis, we can measure the stage of scoliosis with the amount of degree change of the spine. So anything past 10-degree change is where we would start classifying this curvature change as scoliosis. So anything under 10 degrees we would just call a mild lateral curve, where it's not actually scoliosis, just a slight curvature. And most people actually have slight curvatures. I mean, it's very, very rare for us to not have some curve in our body. And in some cases, curves are normal and we actually want curves. But when we're talking scoliosis, we're talking more lateral curvature versus anterior posterior curvature. So we had said anything past 50 degrees would be a time where we would start considering surgery. Now 50 degrees, we'll probably have maybe some pictures up for you to just really understand. When you see these pictures, you're gonna agree with us and say, wow, this looks way different than a normal straight spine.
Yes.
But with these kinds of drastic changes usually comes visceral changes. It's gonna put pressure on other organs. It probably is gonna cause poorer breathing and just a lot of worsening outcomes. But to say that you can't intervene and help someone with these kinds of drastic curvature changes, that's where we're going to argue this point. And with that, I want to then jump into, we have non-surgical interventions for patients with scoliosis. So this is a bracing versus just observation. So bracing versus non-bracing. So that was the control, where they just had people that didn't brace versus those who did. And what they showed was the author suggested that bracing could be absolutely considered as an effective non-surgical treatment for adolescents with idiopathic scoliosis, particularly for those at risk of progression. So again, this was in 2019 now, a couple of years after the study done on surgical intervention. And what we're finding is this is a absolute intervention that you can think about doing before surgery. And again, Doc and I would even recommend you do try this before surgery, because that is going to be very invasive and a conversation that is scary, especially with your kiddos. The last one we are going to talk about today with scoliosis is just exercise-based interventions for scoliosis. And I just want to preface, not only do we do, Doc and I, bracing, but we do exercise with bracing. We really bring the entire package along with chiropractic care too, to managing patients with scoliosis. So this is just exercise-based interventions. Systematic review, meta-analysis is again 2018. Suggested exercise therapy could be absolutely beneficial non-surgical treatment for option for patients with scoliosis, particularly in mild to moderate cases. So again, this is patients who probably have anywhere between 15 to 45 degrees of curvature. We haven't quite gotten to that 15 over, and 15 over is again very severe. So there aren't going to be many times where we have a conversation of surgery or no surgery with 50 degrees. That's going to be something where we want you to get a second opinion with your orthopedic surgeon. But before that state, we're going to argue conservative care is going to get you a long ways before surgery. So Doc, first let's break down why you feel bracing, exercise therapy, chiropractic care creates such drastic change to scoliosis, and why that is a great option first before surgery.
When it depends on age, because if you're going through puberty, your body's aging quicker, and it's also adapting, growing in size. Other functions, other adaptations are occurring as well. But with scoliosis, if you are younger and you are going through puberty, especially if you're taking screenings or x-rays prior to or earlier on in life, you'll notice that the body will adapt and change, especially in hard casted braces. It's going to almost force the curvature to be worse. We came across a patient in the last few months that had this exact same thing go on. They're trying to avoid surgery, kind of obviously. We're going to get to the complications of that here in a sec, but when you go through and you're constricting the body, yes, we want to bring the curvature to the opposite direction, but as they're growing in height and size, it's forcing more rotational twisting, which then can cause more severe problems, more pulling above and below the area, especially from the lower back to the rib cage, and especially shoulder hiking as well, because when they're putting a hard casted brace on a younger individual that's braced, it's constricting all areas of function pretty much from the armpits down. And not only is that uncomfortable, but when you look at how you can untwist the spine, there's a few factors that you have to play into this. One of which, is it beneficial to have this brace? And I would suggest not a hard casted brace, but a brace that will not only support the curves to hold you upright, but also to add in exercise movements that will help facilitate lengthening and or strengthening to cause change to the tissues depending on where the curve is at, and depending on, is it rib cage and spine. More so than anything else, you need constant checkups with constant movements of muscle work, of chiropractic to loosen up the joints, to allow facilitation for the body to adapt. And then you need constant pressure or stress against gravity over time to allow everything to untwist. It can improve to a certain period, but in order to adapt the body as a whole, this is puberty and non-puberty, you need a type of muscle work, you need a type of therapeutic exercise, and you also need movement of the joints via, ideally, chiropractic.
Yep.
So when we look at bracing, it's very, very important, not only at that time, but also throughout the person's life, depending on how much you want to adapt the spine.
Yeah. I think everything that you and I have said so far has been coming from obviously a place of bias because we are chiropractors. But what I do want you to realize is what they do in a scoliosis surgery. If you haven't Googled it, I would recommend you Google it. Mm-hmm. It is one of the most invasive surgeries for a spine you can do. Basically, they take and they use a certain rod to, at each segment, force that segment back towards the middle alignment. And with that, it's a great deal of force put onto that spine, number one. Number two, they now have to keep that spine where it's at, and by fusing rods to the outsides of the spine. So you not only just created drastic shift with force, almost as if you think of taking a crowbar and prying that amount of force over. You know, your spine isn't made of steel. It's far, far less strong than that.
It was made to move and function, yes.
So already putting a great deal of force onto the body. Two, they now have to fuse that entire spine in place. So if you have a great curvature ordeal through the entire thoracic spine, they're rotting the whole spine. With that now has changed that person's life from there on. There's going to be less force you're going to be able to put onto that body. There's going to be less activity. There's going to be restrictions, limitations, and there's also going to be a chance for those rods to break. So again, if you push and you want to do more, especially for an athlete, or if it's just a kid who wants to play, there is now going to be a fear of any injury you're going to need to screening, you're going to need to make sure the rod didn't break, and it's just a constant checkup to make sure that those rods are doing what they're doing, they're staying in place and they're not breaking. Because again, if they break, that's only going to cause worsening outcomes and possible chance of punctures and other things like that. So now, if a patient, in my opinion, starts to have vascular, visceral organ, other types of just worsening health, then yeah, I'm absolutely going to argue surgery as an intervention. Mm-hmm. If it's putting pressure on the heart, lungs, very vital organs that you're going to need to live, then absolutely, I wouldn't hesitate. But if I can find enough of evidence to say, okay, we don't see any of those organs being impacted, it's more just musculoskeletal or functional. Mm-hmm. This is where Doc and I are going to heavily argue surgery, and we can then try to use the things that we just talked about to reduce the curvature as much as we can. Now, again, I just want you to know, we're not stating that we can take your heavily curved spine and put it to normal. That is going to be a guarantee that we can't make. But what we can say is we can maybe try to get 10 plus degrees of reduction of curve, which puts a great amount of quality of life back into the body. And so,
if not even more than that.
Exactly. I'll state 10 plus because I'm not going to be out here guaranteeing that we can reduce a 35, 40 degree curve to straight. You know, I definitely don't want to make those claims, but what I can see from experience and just from colleagues is there's a good chance we can reduce that curve by at least 10 degrees on average. And changing a 45 degree curve to a 35 degree curve is incredible. And that's where the surgeon would agree and say, well, we maybe don't need to go that path anymore because we've taken a lot of pressure off where it needs to be. So as far as what we do, it's very safe and it's very effective. It's a safe and effective try to manage this without surgery. So it's not that we're taking and we're putting you through a torture device that is pushing this spine back to where we want it to go. It's much more, I would say, gentle. Maybe it's not the best word, but it's
More gentle than
surgery. But you'd be surprised at how non-painful and more therapeutic it is. It just unfortunately takes time, because this is just like, you know, if you've ever had braces on your teeth, it takes a year for those teeth to shift where we want them to. And so the molding and the remolding, postural changes, therapeutic exercise, and bracing that we do, it does take some time, but it does it gradually and without, surgery obviously is a very quick, drastic change where we do it over time. So really what I wanted to just kind of end on with that is, if you're going to think about surgery, I would, if you have not yet tried conservative care first, there's going to be only a benefit in two ways. One, if any curvature change that we can give you before surgery, if you're still going to do surgery, is only going to help you, because then that just requires less drastic change on the spine if their surgery is needed. And two, let's say we do create such a curvature change where surgery is not needed anymore, we absolutely are going for that. We don't want surgery as an outcome. So that's kind of what I wanted to hit on there.
And there's another part that, as you were talking, came to my mind. Like when curve happens over a period of time, the body's going to adapt to forces against gravity or positions. And it's one of those where the segment, like a vertebral body, if it has curvature on it, especially off to the side, it's then going to force the bone to break down on that one side in which is holding more pressure against gravity. So when we look on x-rays, we can see the height on one side versus the height on the other. So when we are looking to adapt and untwist the spine or reduce the degree of scoliosis or curvature, we also have to look at, are the bones, have they adapted already? And if they have, there's only so many limitations. Thus also why getting this under control early on instead of later. Later, there's more than likely going to be limitations just due to this fact. But yeah, you made a really good point on, much like Doc said, you got to protect the vital organs, especially when your lungs and heart are working every single second that you're alive. That is priority. But when you do look at patients that have undergone surgery and put a rod in the spine, and obviously it limits tilting movements, rotational, bending, extension, all that. Also, over a period of time, where that rod ends, they don't just stop it and put a whole rod down your whole spine. When the whole body and spine moves at millimeters at a time, it's forcing way more movements at the areas below where the rod is and also where above the rod is, which causes hypermobility in the joints, and then other problems can come from there. And then to add on to that, you're then probably going to need other surgeries to either add on to or to affect the structure depending on what's adapted at that time. So like you may have one surgery early on in life, but you're probably going to have multiple more and multiple other complications, whether it's numbness, tingling, weakness to the arms, to the feet, changing the vasculature to the arms, to the feet. Like there's so many other things going on. So if you have the availability to go the conservative route, unless there's some significant things going on, highly suggested because of the long-term approach, because of how if you add 20, 30, even 5 years down the road, how's your body going to adapt? How is it going to react? And I think it's just one of those to where if you don't think about all the factors before undergoing the knife or all the factors of understanding your condition, it's hard to rely on not only one person's or practitioner's opinion, voice, but even for multiples to see other multiple opinions. But is it best for you? And that's where the knowledge comes into play. But
good point. If your first stop was the surgeon and he's saying surgery, I would recommend a second opinion before you proceed.
Yeah, if not
for sure.
third or fourth.
All right, so that's scoliosis, and we're obviously very passionate about this because our job, in our opinion, is to prevent any invasivity that we can. We are preventative practitioners, and surgery to us is not a failure, but it's definitely something we're fighting against because we just know how much it drastically changes the body and how much it can decrease longevity of the joints that we're trying to help you obviously prevent aging, degeneration, and pain over time. So, all right, Doc, moving on to other conditions of the torso, thoracic spine. This is a kind of a switch in the area of the body we're gonna switch to. So instead of the spine, we're gonna go right to the front of the sternum and ribcage, costochondritis. Now, this is something that I know a lot of people struggle with. They just for some reason cannot seem to kick the tenderness and pain that they get around their sternum. Some of them have probably even mistaken it for a heart attack. So, Doc, dive in. What is costochondritis and how does that affect the pain in the spine and the sternum?
Yes, so costochondritis is inflammation where the ribs on the front attach to the sternum, which, much like Doc said, can cause this weird chest pain, and it can cause inflammation around that area. Now, when we look at how you can treat this, there's a couple different ways. First off, we have to get the inflammation under control. So other lines of literature and studies that have shown improvement in pain would say NSAIDs. Would be a really good top to go. And I think there's some truth behind that. It's out of our scope to prescribe any type of NSAIDs, but outside of that, we want to look at a couple different ways that we can treat this instead of just relying on a pill. When we looked at this, there's a study that came out 2016 in the Journal of Orthopedic and Sports Physical Therapy by Fernando et al. And they broke apart. It was an RCT, or a randomized controlled trial of 60 people, half of which did massage therapy, joint mobilization, muscle work, and therapeutic exercise on top of that. The other group just did therapeutic exercise. So they wanted to see the difference. If we do manual muscle work with exercise, opposed to just doing exercise, is there a difference? And they notice a huge improvement in not only lung capacity and how well you can open up and contract the ribs via breath or just even any movement in life, but also in terms of the pain intensity. So we know that there's a few factors in play, and I think of the which, going back to the part, if the ribs collapse together, especially on the side, it's going to affect the insertion origin point on where those ribs attach to the sternum. So if you're affecting the inflammation where the ribs attach and opening up and not allowing them to be restricted, it's going to improve the function, blood flow, neural flow for that healing to occur. But yeah, it's all about not only getting out of pain, but improving the function long term. But
really the only thing I got to add with costochondritis is the inflammation point that you stated. You're going to have a couple of supplements that you can take. Turmeric is going to be one, very helpful with anti-inflammatory properties. The second one is more helpful for the joint synovium itself, which is glucosamine chondroitin, which I know has a lot of research regarding prevention of costochondritis, but also reducing pain. I think a couple more was ginger, boswellia. There's a few more that I know you can look up, but give those a try too, or at least research them if you are having this, because there are times where I know patients will struggle with this for more times in a row. It's recurring. But like Doc said, if we're going to take and try to treat this from a root cause standpoint, you're going to look to see, first off, what kind of posture do you have? Are you putting pressure on this sternum in ways that you aren't giving relief, whether it's office worker, truck driver, someone who's just constantly rolled forward, chest. You're going to see patients that maybe can't breathe very well, obese, what have you. So it's just making sure that we take a look at that and try to create changes there as well, versus if you don't change that and you just continue to take a supplement or a pill, is that really where you're going to see change? So just something to take note there. Next up, thoracic outlet syndrome, Doc. Do you want to jump into that? And we'll kind of talk on surgery versus non-surgery for that too.
That's a good point, yeah. And so when you look at known as TOS, or thoracic outlet syndrome, that's mainly where there's compression of either nerves, veins, or arteries that go between the clavicle and first rib. Oftentimes with desk workers, you're going to notice this weird numbness tingling down to the arm. You could also notice that you have cold hands, or if you have deformities to the clavicle via an accident or injury earlier on in life, that'll also affect the spacing between the first rib and clavicle. But the reason why it's important is it's where's some of the root causes, and then also if it's affecting the vasculature, whether it's veins or arteries, there's a huge complication to where it can cause blood clots, especially with certain movements. That's, if you have any symptoms going on, either cold hands or one hand is colder than the other at times, it's just go get checked out, go get screened. It's more for the preventative costs if there is something going on, highly suggested.
Yep.
But yeah, if it's compression of the nerves, then that's where we're gonna get either, if it's over time, possibly even paralysis to a certain extent, numbness, tingling, lack of function, lack of strength. There's a lot of different things with that. But in terms of surgical versus non-surgical, but Doc, what's your intake? Have you seen patients with this? I know
For sure.
we've seen a lot, but
Yeah, for sure.
Yeah.
What we typically find is it's mild to moderate in most cases. Severe TOS is immediate surgery. You'll find for the worst case scenario of TOS, and you can even look up pictures, we may even show you a picture, is one arm is double the size of the other arm because of lack of blood flow to the area, so there's swelling. It might even be a different color change than the other one because of just complete loss of blood flow and nerve flow to the arm. So that's severe, and that is immediate surgical referral. Now, in cases where it's moderate to severe, where we're not actually getting that, but it's to the point where you're getting numbness and tingling every day, it might be cold, that's where they would argue, if it's not getting better after so long, then surgical intervention is something that they would do. And really what they do is they just remove part of the rib or the clavicle to help create space for these structures to finally not have compression. So there's a couple of studies here that we have. One study was Journal of Vascular Surgery. Looks like that was a study you had brought up, Doc. Do you want to just talk quickly about that one?
Yeah, thank you. So when they looked at this, it was in terms of the long-term outcomes of surgeries. It showed that there's a systematic review and meta-analysis of either going and having surgery or not. And the study found that interventions for short-term pain relief and functional improvement were variable. And I think a lot of that will go down to with the positions against gravity over time that people find themselves in. If they remove certain bones, it can affect the glide and stabilization of those arteries, nerves, veins out to the arm. And I think that's where some of the variability can come in. Also, if you have shoulder problems, increased weight, head forward, I think that's where a lot of the complications can come in. But the authors via this study suggested conservative route should be considered first, opposed to surgical route, if we will. But yeah, I think that just adds on to the point.
Yeah.
To what we're saying.
This is probably going to be something that you'll hear us say on every single podcast, which is conservative first before surgery. And you know, we can say that all day. The only thing is, if surgery is needed, it's going to be in those incredibly drastic cases, like we preface first. So same with scoliosis. Incredibly drastic cases where vascular and organ function is being impaired, surgical, yes, like not a question. TOS, if your arm is purple and about to fall off, yes, like we're not up here saying we can fix you. Like, nah, you don't need a surgeon. Just your arm's fine, we can fix it. No, what we're saying is if it hasn't gotten to a point yet where that is needed, conservative care can go a long way. Absolutely can, and it might even prevent surgery. So that's really, I just wanted to hit on that. So next up, Doc, this is an interesting one because I think a lot of people, without even knowing it, know what this looks like. They may not know the name of it, but they know what it looks like if they've seen it on their friend or someone who's had this. But talk about Pectus Excavatum and what it looks like to most people, and then of course how they manage it.
Yeah, so Pectus Excavatum comes from maladaptation via the sternum diving in and causing almost like a bowl shape, but it also allows the ribs, which go from the back side to the front side, to not attach properly, and instead of the rib cage sitting upright, it allows everything to go downwards, which doesn't allow proper inhalation, exhalation. A conservative route to where we can do myofascial release muscle work on some of the spaces in between the ribs, working on decreasing the restriction on the backside, and then working on breathing techniques every single day continuously for months. Now there's certain limitations with that. There's a therapy that I actually just found out about known as the vacuum bell theory. It's where they put an inflatable balloon behind the sternum. They pump it up, which allows for the sternum and rib cage to go from inwards to outwards, thus improving the capacity of how they breathe. There's a study that they did more from like the pediatrics patients, and this study was back in 2019 by Scheuer et al. From the Journal of Pediatric Surgery. They noticed, and this was 50 patients that were more moderate to severe, and they looked at this in terms of improving the chest wall deformity and also the reduction in the Haller index, which is pretty much just measures the intensity of the dipping down or the bowl-like structure, if we will. Now with the study, it went from on average for patients from a 4.8 to 3.2, more or less the dip diminished, thus also improving the lung capacity, improving the function of taking a deep breath in, and also the appearance as well. But yeah, that I think, like even for patients coming in, because we see it every now and then, and it's not as common, but it's also not incredibly rare, to where like if a period of conservative therapy, we're not seeing changes, then I'm definitely suggesting there. And it depends on, like I said, the severity, but yeah.
Yeah, the only thing to note on that is if it's really severe, it'll push on the heart. And that's where I know that surgery is definitely going to be needed. That surgery is, again, super invasive and it sucks. The one that I am familiar with is they take in that, almost that curved bent rod. I don't know if you've seen it where, think of it like a curved rod, and when they're putting it in behind the sternum, they go in and they torque the rod so that this curved part pushes against the sternum and push it out. Now again, I know it's super invasive. I know it can be helpful. I haven't looked into the research regarding its effectiveness, but if it's to the point where it's now pushing on the heart, obviously that's a super important surgical necessity to get that straightened out. But of the patients and friends that I know that have had this, they've never needed surgery. It's more aesthetic. I'm not even sure. I know one of my friends who has it, played football, was very athletic, super fit, incredibly muscular. Like, it didn't really affect him from what I know. It's more just that unfortunate curvature change and alignment of the ribs that come with this. And then of course the aesthetic of having a large hole in your chest. So, which he would use to do body shots out of his chest when we were in college. So I don't even know if, again, that was just the funny thing of that. But anyway, no, I don't think it's something that requires surgery that often. It's more just making sure that you can, like you said, try to limit the effects over time.
That's a good point.
Next up, Scheuermanns disease. So Scheuermanns disease, probably a lot of you have have seen a major symptom of Scheuermanns disease, and that's the large humpback of patients who have, it's usually middle-aged to older age women who get this too because of advanced osteoporosis. But Scheuermanns can obviously be in younger patients, adolescents even. Doc, do you want to just jump in quick to Scheuermanns and what that looks like?
Yeah, it's pretty much just increased curvature where it looks like a wedge-like formation to where the front part of the bone starts to diminish and the backside still holding its structure. So it has a mimic effect of a wedge-like structure. It increases the curvature, much like Doc said, and it's also going to limit rotational movement. It's also going to limit lung capacity and how well you can breathe. Found out that there's a couple interesting things with this one. Depending on how far into this and the limitations you have, chiropractic adjustments, which allow glide of the joints, will help significantly. Also with physical therapy, muscle work. But if the structure and the bones have changed over a period of time, and if we didn't catch this earlier on, there's only so many limitations you can have. However, for patients that have very, very severe and anywhere from 50, 60 years old, or even from 40 to 60 years old, I think there's a point to be made to possibly looking the surgical route, obviously getting multiple points of view and opinions. But there's a study that came out, published in the Journal of Bone and Joint Surgery in 2019 by Otani et al. It shows that even bracing in the adolescence with people that have Scheuermanns disease or the start of have shown a huge benefit via bracing. Upwards of 70% of the patients avoided having the surgery after the bracing treatment. So nice. I think if you can catch it sooner than later, if you notice that your kids are have increased rounded back, that is something that you absolutely want to consider. Like if there's anything weird that you think that your kids are looking or functioning like, obviously get screened by a doctor that specializes in the spine or the body more from a conservative route. But
absolutely.
Yeah, Doc, is there anything else I guess you have for Scheuermanns
No,
disease?
not at all. That one, we don't see a lot. I don't see a lot of it. I definitely see more of the osteoporosis, Dauerger's hump than anything, which again is similar to the humping that is caused by Scheuermanns. But no, like you said, usually with conservative measures, it can prevent surgery. That's with a lot of things. So I think, Doc, let's jump into the major causes of mid-back thoracic spine pain that we typically see, and obviously the supporting research that we have, either surgical or non-surgical, and let's kind of dive into that. And then that'll be fun. We can end with how breathing incredibly impacts this body of ours and the tools that they can take home, obviously, to keep up the ribcage and torso's longevity. So I'm not going to hit too heavily on these. I'm going to jump kind of right into management and treatments. But typically what we find pain in the thoracic spine is usually from muscle strain or sprain, disc herniation, osteoarthritis, radiculopathy, which is again just putting pressure on a nerve and it's causing shooting pain elsewhere, or a vertebral fracture, which can be caused from an accident, a fall, an injury, those kinds of things. So let's jump right into surgical intervention versus non-surgical intervention for a lot of these. So first off, surgery is what I'm going to start with. I only have a couple of the conditions that we previously talked about where I can talk surgery is going to be more properly used for these interventions. Obviously, a strain, sprain surgery should never really be needed. Osteoarthritis, very rarely I would argue that you would ever need surgery. So it's going to be for two things. It's going to be for a fracture or for a disc herniation. Those are two severe conditions that cause a lot of pain where a lot of people would want surgical intervention just to reduce pain. So number one, thoracic fusion for a fracture. Now, if someone got into a car accident or had a severe injury and you needed to stabilize that fracture so that the spine wasn't moving away from each other and putting drastic pressure onto the spinal cord, which could cause paralysis, maybe even death, then absolutely. Thoracic fusion surgery is super effective at stabilizing that fracture and reducing pain over time. So that's just one study that I had brought up. It was the surgical management of thoracic spine fractures, a systematic review. But yeah, if it gets to the point where you need life-saving surgery, yeah, absolutely surgery is going to be necessary. Now, it gets to a point where you need surgery for managing a disc herniation, which is something that probably came on gradually over time, not something that was just acute, it just happened. This is something where as you've aged, your disc has become less healthy, and there was now a break in the outer portion of the disc, which causes a herniated matrix to leak through and push onto the nerve. So we have a couple of I have studies here for, and I have studies against, because I always want to come from both sides. So
Good point.
do I have research here for you that shows effective management of herniated disc, thoracic herniated disc? Yes, I do. It shows that surgery can be effective to treat disc herniation, particularly in cases of severe or neurological deficits versus conservative care. Now, I want to note, if there was neurological deficits, then yes, I'm going to argue surgery. Now, this is where you're going to have change in breathing, possibly change in the ability to move, the ability to function, might even have paralysis of structures. Now, yes, that's where conservative care over time may not get you the outcomes that you need, and surgery is needed to reduce any long-term loss of function or change in structure. So now, if there is not neurological change, or if it's just pain you're dealing with, yes, it's helpful. So this one was outcomes of surgery for thoracic disc herniation on patients who had pain and just a decreased quality of life. What they concluded was surgical treatment can effectively and safely manage disc herniation, but what they showed was it was a short period of relief versus long-term outcomes. So again, with most surgeries that we see musculoskeletally, it's not going to be long-term, and it's something that's going to be at least helpful for a short-term period of time, and over time the pain might come back, where that's where you need to start figuring out, okay, what's causing such drastic strain to this disc, and why is it causing it to herniate? So over time, that's something that you should be managing conservatively. If it got to the point where you need surgery, okay, surgery is something that you chose to do. It doesn't mean that the problem is fixed, and the question should be, why did it herniate in the first place? So yes, short-term relief was given. That's great, you got your relief, but long-term outcomes, there's a good chance it's going to come back, is what it's saying, and it's something that you need to work on again before it does come back. Lastly, conservative versus surgery in thoracic disc herniation. The author suggests conservative management should be considered as first-line treatment for thoracic disc herniation, reserving surgery for cases that do not respond to conservative measures. So, what did I say before this? We're going to say it day in and day out. Try conservative measures first before you do surgery. And if you do surgery, if the pain or if the condition's not drastic enough, there's a good chance it's only going to help you for a short period of time. So, that's what I got for surgery. Doc, do you want to say anything?
I think you hit on
I feel like I'm a broken record, but I don't know. I want to make sure I continue to drive this home in your guys' brain. Surgery, yes, it can help in certain cases, but most of the time, if there's not significant, drastic, scary condition changes, more than likely it's in my opinion, going to be a only short-term benefit. Sorry, go ahead.
No, you're good, and I think you hit the nail on the head. Just even not only looking at the complications of even having the surgery, but also when undergoing the kneel, you have to also look at the tissues that would also have to be recovered and healed and worked out, either via physical therapy is probably primary on that, to a certain extent chiropractic, but mid-back wise, there's only certain limitations that we have with that. So like there's other complications that get involved outside of the condition of the herniation. But yeah, no, that was perfect.
Yeah. Next up, conservative care. I have a lot here. I don't think I'm going to jump into all of them. I'll just kind of jump into the uniqueness of each of these. Yeah. So exercise therapy, like Doc was saying, incredibly helpful. Should be first line managing this kind of pain. In this study, it just noted exercise therapy was highlighted as an effective non-operative treatment for managing mid-back pain. Next up, yoga. Yoga found to be effective at modifying risk factors for not only mid-back pain, but factors including cardiovascular disease and metabolic syndrome, which may include reducing pain and improving function in the thoracic spine as well. So I thought that was cool for them to take note of for that as well.
Cool.
Acupuncture, supportive for managing chronic pain, especially in the mid-back. Thoracic spine manipulation or chiropractic adjustment is another name for that. This was a good one. I really liked this because not only did it help mid-back pain, but in the patients that received chiropractic care, it actually helped manage their neck pain. I mean, it makes sense to us, but for those of you that are wondering how does adjusting the back help with the neck, again, the body's connected. There's a lot of the times where we have curvature changes in the back or the neck that plays a role in forcing not wanted amounts of strain on the other part of the body, and it kind of is a chain effect. So we have the ability to improve the mid-back function and rotation and structure. It actually can help correlate improving strength and motion above and below. Chiropractic manipulation for the thoracic spine, again, specific measurements showed improvement of pain scores, function scores, and patient-reported satisfaction with the treatment. This again was PT. I'm going to skip over that. Acupuncture again, I already know. Yeah, that was really it. Just showing these are the kinds of treatments that have been studied well enough to be included in systematic review. And when you have enough inner evidence to be included in a meta-analysis or systematic review, it just shows that there's a higher body of evidence to actually look at this. There comes a time where if it's a newer treatment, a newer modality, if you don't see anything that has a systematic review or a meta-analysis, there just isn't enough evidence on it yet. But since we have these kinds of research, we have this research now that we can confidently say that these conservative measures are great in the beginning and as first-line treatments for mid-back pain before you look for surgery. That's what we're just trying to prove. So
Absolutely.
Doc, anything before we move on to breathing and tools?
No, I think that was really good. Like, obviously, we've said it again. Doc said it 2 or 3 times today. I think he should say it almost every time, depending on what topic we bring up. But conservative route before surgical, not only going for the assessment, but actually going into a very minimum a month, if not a few months to a couple years before even considering the surgical route. But it also depends on where you caught some of the conditions, what stage of your life, and is it acute? Like, was it via a motor vehicle accident where it's like we have to go right now to get this under control? Like, obviously, so yeah. It's having the understanding and education to knowing where you can go for the best outcome throughout the rest of your life for this condition.
Good point.
Yeah.
I like the way you stated that. So this is a part of the podcast we've been kind of excited to get to. Let's talk about breathing, Doc. So you want to just kind of touch on how breathing can drastically not only improve just the overall function of the body, but how it can actually impact curvature changes to the spine.
Absolutely. And then I'll go into this briefly because then I definitely want you to take apart this a little bit more, especially with some of your background. But the breath and how the lungs can expand and then relax. A lot of that has huge implications of brain health and how the brain can connect to the tissues of the body. So when we look at breathing from a structure standpoint, if we notice, like I said previously in this podcast, if you are sitting for periods of time at a desk or you find this position often throughout your day, even driving, there's so many other things. Try taking a breath in. Now sit up. Now try taking a breath in. You can notice visibly there's a difference between forward and backwards. Yeah. And over a period of time, if you're in this position, not only is it going to change your structure, because the body will only send resources to the areas that either it wants to improve on, or it'll send resources to maintain the structure based on what position you're at for a period of time. So if you're challenging extension, if you're challenging breathing with rotational movements, it's going to adapt and open up the lung field. It's going to allow the ribs and the tissues, intercostal space between the ribs, to open up and contract more. We'll get into a few other tools here in a hot sec, and how it will affect not only the structure, but it also is going to affect calming the system down or increasing the awareness, how alert you are. And that's via the breath, like Doc said. So if you want to increase the awareness, the drive, the focus, it's taking more inhales than exhales. So it's more of hyperventilation, if we will. And that can be combined with other types of code therapy and whatnot. But in terms of, for this sake, if you want to increase your awareness, if you want to increase the energy you have throughout your day, waking up in the morning, going through a bout of either meditation, exercise, you can even do this in the shower if you like, whether it's the water hitting you in the back of the head spine, taking more inhales than exhales for a minute, 2 minutes straight. That will significantly impact how your function is starting off the day. Now, let's say we want to calm the system down, or if our mind's racing and it's hard for us to calm the mind down to get to sleep, you can either go shower route, more hot water, or you can do more long exhale breathing instead of inhalation breathing. So be more focus on the amount of time you exhale versus the amount of time you inhale. And that will also calm the system down. But those are two different ways that the breath can not only affect the structure, but the awareness, the calming of the system. I guess, Doc, what's your take on breathing, breath meditation practices? Yeah. How do you use this patience?
That was good. That was beautiful. And I think the keynote there was increasing energy, alertness, awareness, inhalation. Calming down, parasympathetic is exhalation. So great way, like Doc said, to bump the morning is big inhalation breaths, 10, 20, 30 of them. You might even get a little woozy, dizzy after, like he said, kind of hyperventilating, but it does make a difference. And you'd be surprised at how much your body loves to have that oxygen, extra oxygen. So many people don't take a deep breath, like a truly big deep breath. Like, when's the last time you tried to breathe so in deeply that it almost stopped you from breathing and you had to breathe out? Like, that extra inhalation really does grasp for the alveolar sacs to get the last bit of oxygen in those sacs. And that does make a difference with the body. So there comes a time where I know it's super helpful, where research has shown where you're taking a breath and you get to that, like what you would consider your last bit of inhalation, take 2 quick bursts of inhalation, so it's, and then breathe out. You will increase your ability to take in oxygen by 90% more. I think it's by, I think typical breath, you only get between like 40 or 60% of the sacs inhalated with oxygen, but that last couple breaths can get you up to 90, even 100%. And not many people take those big, deep of breaths. And that's where, if you're going to have crucial impacts on performance and just ability to get oxygen everywhere you need and take in oxygen, it's that inhalation that's going to do that. So there are times where I'm laying in bed when I'm just woken up and I'm focusing on inhalating and doing that to the point of getting those extra deep breaths in after I can't breathe. And it's just good practice for good lung function and health. Second one he talked on was exhalation. That one is focusing on, I like to do 2 seconds in, 7 seconds out of exhalation. Great for improving vagal tone, improving parasympathetic output, making sure that you're relaxed. It's also making sure you're doing it nasal breathing wise, so in through the nose, out through the mouth. Again, impacts nitric oxide, your ability to induce anti-anxiety metrics, those kinds of things too. So no, I think with the breath, there's a lot of things that we can touch on. And I know we talk about how we even want to do a breathing podcast just because of how much we can talk on the breath. But if we're not breathing in through the stomach or with the diaphragm, we're already hurting the impact of our breath. So 1, you need to breathe through the stomach and with the diaphragm. That's number 1. Number 2, breathe through the nose. That's going to be way more effective than mouth breathing. We talked on that, I don't know whichever podcasts ago. And then 3, if you're going to try and improve your breath, try to do the double inhale after the resistance is met. That's going to push for better oxygen absorption and basically alveolar sac grasp of that oxygen. So that's kind of what I have as far as the breath. And then of course how it impacts the spine, like Doc said, when we're rounded forward, we can't breathe as well. It's in putting strain on the posterior portions of the spine and the tissues. We're going to have more pain, we're going to have more stress, and you're going to get that upper neck, middle of the shoulder blade pain that just doesn't go away, and it's just tense. Even massages doesn't even help it. You're just always having that pain. You'd be surprised at what improving your posture and your breath can do to those things too.
Yeah, and even adding into like what practices you can do for the longevity of your portion. Doc said it, I touched on it a little bit. Obviously, focus on inhalation or exhalation via what state you want to find yourself in. But in terms of the structure as well, just adding on to the point, as you take a breath in, all the tissues are going to be expanding, but add in rotational movement, add in flexion, extension as you're holding your breath in. So it looks something similar like, and notice where is some of the pressure and tension coming from. If you notice on the front side, you maybe want to work on just general maintenance, putting your fingers in between the ribs, going back and forth as you breathe in and out. And then if you're also a higher end athlete as well, to where you want to maximize your performance, every small thing works really, really well. So going back to what Doc said, more exhalation gets the parasympathetic drive back to re-regulate the homeostasis, or pretty much try to calm the system down after an intense bout of work just to get to baseline, which will help for the recovery aspect. And it's also increase the oxygen, communication, and travel, if we will, to the other tissues, and then get the waste products out. But yeah.
Perfect.
Yeah.
And then lastly, I think, Doc, if you just want to touch on what are some tools that those listening and patients can do to improve the longevity of their mid-back and torso and rib cage?
Yeah. So maintenance and assessment of the body, much the same with the other series, is by going through the biggest range of motion possible, pain-free. So noticing, are you having discomfort with any type of movement and how you move your back or spine? But to zone in and target the thoracic spine and rib cage, you want to make sure that the areas above and below are stabilized. So that's involving contracting or squeezing your torso, and also your upper back shoulder girdle. So when you go into this, you want to start by bending forward just a tad, rotate as much as you possibly can, extend back, untwist, untilt, and then come back to center in both directions. Also, when you contract your core, you're going to notice more tension on this back thoracolumbar junction or the TL junction. That's where most of the twisting occurs. How we want to allow movement throughout the body, especially allow the glide of the joints, and not only to take a breath in as you go through this, but you can also do this breathing out. You're going to notice a little bit more motion as you breathe out or hold your breath on exhalation versus inhalation, but to have better communication via the rib cage to the thoracic spine, inhalation works much better. So that's going to be one. The other aspect is, and I don't think I brought this up in the past, to allow long axis traction for recoil of ligaments, tendons for that healing purpose. Bounding, jumping work will do actually really, really well as well. So keeping your core, torso contracted, legs contracted, and the only thing I want you focusing on is like the spring jumping of your feet. So it looks something similar, and you can notice the reverberation throughout the body. If you want to keep the core, legs, and arms contracted, and then have loose movement of their upper back and also rib cage, there is also a little bit of a difference with that as well. You're now more springiness, which allow more glide of some of the joints on the top. But anytime we can get movement up and down, not only forward, backwards, side to side, but movement in that Z-axis, that will allow for the tissues to not only distract but come back together, so we can allow pumping in the discs as well. Obviously, if you have a disc herniation, you definitely don't want to do that, but you want to work into it over time. As we go into the other two areas that are a little bit more common, there is how you look at the rib cage from bottom up, known as decompression therapy, or even top down, which we can look at as inversion therapy. So I guess, Doc, I guess for your standpoint, for decompression tables, to where it distracts the pelvis from the rib cage and the spine, oftentimes for lower back disc problems, degeneration, I guess, what have you seen beneficial wise with that? And is that able to help the thoracic mid-back as well?
Yeah, good question. So the kind of therapy the doc is talking about is, well, most people know it as the inversion table that you can purchase, strap your feet into, tip it upside down and hang. That's, available to the most population. You can buy it off Amazon, but there are much more specific and advanced decompression tables that we as chiropractors use. Other providers, I'm not sure if they use it or not, but what basically you do is you lie down and there's a harness that's strapped to the pelvis, and then we can choose a certain amount of force that can be then pull the hips and pelvis into what's similar to like a wench on a vehicle. And what'll happen is you get this decompressive force put through the lumbar spine, even up into the lower thoracic spine as well if you pull hard enough. And there's certain benefits that patients can get with that. I have been in practices where it absolutely can make a difference. The current research for managing chronic low back pain says decompression is not something that you should use for managing chronic low back pain. However, for radiodiculopathy, herniated discs, other conditions where there's compressive forces, I do think decompression, given the name, obviously can be a benefit. So absolutely, I would recommend it for those cases. You might even be able to prevent surgery with that therapy, along with, of course, chiropractic and physical therapy, I think should always be used in those cases as well. But given just most people can do inversion at their home, the only thing that I would make sure that you note is don't choose the tables that just tip upside down. Make sure that they have the ability to tip at an angle, not all the way upside down, because what will happen is patients in pain will try to do that therapy, and two things will happen. One, so much of their body's force will then distract their back, and it will cause too much force to be put on the tissues that are guarding and are protecting the injury that you have. And those spasms will seize up. You will get incredible pain and you'll be stuck on that inversion table. You'll not be able to get off by yourself. And too many times I hear firemen and police people getting called to people's houses because they're stuck upside down on an inversion table because of the injury that they sustained. They thought the inversion table would help them. So be careful. Please, before you even do that, let a provider see you so that they can give you a good recommendation. But do the tables that either go to like a 30-degree angle where you're not tipped all the way upside down, you're just tipped at an angle. Those, in my opinion, are what I actually recommend my patients do. I don't think you should ever tip upside down. Your body's weight is just way too much force being put on those tissues that are injured. So like a 30-degree angle is a gentle enough pull where you're getting some distraction and it's not too much force to the lumbar spine. And then of course, if that's still not helpful, then obviously make sure you see a provider so you're not trying to manage yourself.
And those are really good points. To add on to also the reasons why, going back to the injured area, like let's say it's also not injured, because we've been asked this question so many times, will this help, will it not help? I think even not seeing a practitioner, you have to understand what your structure is at, because if you have tilting of segments or excessive curvature, if you go into distraction, it could cause some of the bones that are already tilted to jam up and cause more problems, also causing guarding muscle spasm tightness as well. So I think before going in and buying an inversion table, or for that matter, even just hanging from a pull-up bar as well, which if you're going to look to do that, try to have your feet in front of you, which helps distract, especially in that TL junction, a little bit better. But to understand what your structure, where it's at, and if inversion therapy is beneficial for you. But yeah, no, I think those are really good points that touch on. Cool.
Alrighty, well, that was episode 7. Thank you guys so much still for continuing to support us. Please like, subscribe, share this with those that you think will be helpful. And again, thank you guys so much for watching, Doc. Woo! We're good to go.
Thanks for joining us on The Functional Code. For more evidence-based health insights, subscribe, rate and review wherever you get your podcasts. Remember, your journey to a healthier you begins with understanding the Functional Code. Until next time, stay well, stay informed, and embrace the science of living well.